Namaskaram and a very good evening to all our viewers. Strategic partner എന്ന നിലയിൽ ആത്മ ഫൗണ്ടേഷനും ഈ പ്രോഗ്രാമിനോടൊപ്പം ചേരുന്നു. And today we have with us Dr.Amar.S.Fettle, the State Nodal Officer for Covid-19. Let us now begin today's program.
Good evening. It's a very big privilege and my pride to be invited by Atma Foundation, of which many of my friends and also my wife also is a member. It's a very fulfilling thing that I'm invited to address this esteemed group. So, respected members of Atma Foundation, Institute of Engineers, and especially Dr. Sabu, who is just like a brother to me because my classmate's sister is Dr. Sabu's wife. So Dr. Sabu's name has been part of our academic family for a very long time, ever since we are doing our graduation MBBS times long back. So in short, really happy to be here with you. In fact, Dr. Sabu had given a very wide introduction. He had also asked me some questions which I told him I'll answer later as to, for example, how long I had been in this communicable business, communicable disease business. So I've been here for the past, inside this, I was just an ordinary doctor practicing as a pediatrician, head of a department in General Hospital Trivandrum. But then this H1n1 epidemic came 11 years back. It was called swine flu in different states, but here we called it H1n1 by its proper name. And when that came, I had been trained previously by WHO for outbreak and management of outbreak investigation and management of international public health emergencies. So because of that background, I was immediately made nodal officer of that program. And don't believe what Dr. Sabu said. I did not do any control. It is a wonderful team that I happened to be able to build. So it was all the victory of that team that gave us all this great benefit. So that it was a wonderful teams we had at all the districts. So I'm very thankful to those teams. And I'd been trained here and abroad, but abroad my training was basically in Sweden, very short period, adolescent health. I'm also the state nodal officer for adolescent and teenage health in Kerala. And so it was sort of not really my culture. I had basically an interest in joining for training programs and going to attend training programs and coming in, bringing them back to Kerala and disseminating these things here in our state for the benefit of our public and our doctors. So this is basically what I've been doing. Now, since the topic of the day is that COVID-19 and all that, I think with your permission, shall we go to the slides? I've brought up a set of slides here, which will explain the story of COVID. And it's not a very comprehensive or what we call a very total account of the whole episode so far. But certain things which I thought are significant I picked out from the whole thing. It's a huge gamut of innovations, experiences, and challenges. Out of those which I thought are significant or which touch my heart at some point of time, I have tried to bring out those so that we can just I can open my heart to you and talk about these things. So COVID started with a bang. Can we go to the next slide? It started with a big bang in January. For as far as India was concerned, it was January 30th when the first case came to, of all places, Thrissur itself. It was Thrissur itself where the first case came. So, 1 second. Yeah, it came to Thrissur. So, but that was January 30th. But I will strongly remember right from about January 18th or early January, we had heard certain rumors on the internet and on the WHO site and all such places about something unusual going on in China. So we have a group here called the Disease Public Health Control Room or Public Health Division inside the Directorate of Health Services. So sitting there with the Additional Director of Health Service and our team, we discussed that there is something going on in China, and isn't it a fact that there are so many children from Kerala who study in China? And if it is going to be something messy, surely all these guys are going to return back home. And that means if it's a dangerous disease, they are all going to be bringing it back to India and to Kerala. So I think we need to be prepared. So this was the tone of the discussion at that time. And in fact, what we did was very early, before this arrival of the case in India and Thrissur and all that, we had sent out certain emails to all our district heads saying that something funny going on. Look out and watch out for people who arrive from foreign destinations, because Government of India had not launched airport surveillance at that time. So we advised our people to watch out, use our field staff to watch out for people coming from other destinations. We asked our doctors to be aware that if you have to ask the history of foreign travel also when you encounter any common or unusual illness. So these things we mentioned down the line. And then very shortly after this, we got enough information from the Government of India, Ministry of Health and Family Welfare, that formerly there was this disease called coronavirus infection in China. And international travelers are going to be traveling here. And we are launching airport surveillance over all the international airports of the country. And states are supposed to augment all the surveillance activities. Now, I say augment because you know what happened? From 2009 onwards, when we had the first big pandemic in recent times, because things like Spanish flu and all those are distant memories, our generation did not deal with those. In our generation, one of the biggest pandemics that we had to deal with was the H1n1 pandemic, which started from Mexico and then swept the whole world and took so many lives. So that we were fortunate to have dealt with that in a very good, exemplary manner. In fact, we had one of the best track records in India of the lowest death rates and so on and so forth. So we had that experience. And for part of H1n1 management, we had the system of airport surveillance at harbors, then also isolation units in hospitals, and isolation wards, and ventilators. And this PPE kit, now it's a common household name, PPE kit. But this PPE kit was something quite new even to the doctors at that time. So PPE kit, all this was brought in at that time. Everything was very scarce. They were all coming in on cargo flights from Delhi and other Government of India store depot cities. But and they had to be distributed to all the districts in Kerala. So we had immediately formed a huge team, and this the rare medicine at that time, which was rare, which called oseltamivir, that started coming in small quantities. This throat swab is now another common, it's on everybody's lips, throat swab. But this throat swab was so new at that time, and so throat swab and taking the samples and putting them in a minus or say 2 to 8 degrees centigrade condition and transporting them to distant laboratories by air or by train and other things, that was all new experience. So we got a sort of rehearsal at that time for the next few years. Our state was in a continuous rehearsal and practice mode, not a rehearsal, actual practice mode of all these things. So whatever we are seeing now, the whole state had practiced in an intensive mode at that time with a lot of victory also. So that was a very good thing so that's why I say it always pays to be prepared. And I have written one word there, IDSP. IDSP is a short form for Integrated Disease Surveillance Program. So this is our what you call radar. We have this thing which is a surveillance program. Surveillance means we watch out for anything happening in the at the grassroots level. Even the smallest things, even the rumors are accounted for. In fact, you might find it very funny, but our health centers, they have a register called a rumor register, where any little rumor that the health staff pick up from the field is entered and either verified and crossed out or verified and then taken up for action. So this is a rumor register, funny name for a register. So, then this airport surveillance, screening. Screening is, what do you mean with screening? It means that you look out for people who you suspect they might be carrying a disease and grab them at the airport where they come in after international travel, or at a harbor, or sometimes at the road entry points into a state or rail entry points into a state. At that time, we basically focused on airports and seaports or harbors for international travelers. So that was another thing, that the screening program. Here also for COVID, we did a lot of screening. And our screening was a big success because of the rehearsals we did at that time, the mock drills and the rehearsals and the entire continuous, we maintained that for 1.5 to 2 years, that continuous process of screening was done for such a long time, from 2009 onwards. Then now, part of preparation for anything is anticipation, projection, and extrapolations. Now, anticipation, that's what I just now mentioned a few minutes back, because we saw this, thought of China, thought of the medical students there, so we anticipate it's going to come. And when it comes, how many students are there? So how many people will be coming? How many people would each district be receiving? So then what kind of facilities do we need? And then we projected that number of patients we might have, the number of wards they might need, the number of isolation beds they will need. Such things we also projected at that time. Then we also tried to develop some worst case scenarios, because things can stay in our hand or out, they can go out of hand. So in case they go out of hand, those are the worst case scenarios, because these are essential not to get scared, but to build up the intensity of our preparations. And there was something called gap analysis. It's also a word, I think, I'm sure that you people, all of you, because you are all from a technical background, that's what I gather. So gap analysis, because we think some things are paka, but things might not be so shape. There might be gaps here and there, which can be fatal and have disastrous consequences. So we did very, very extensive gap analysis of our facilities, manpower, infrastructure, our what you call our buffers, and all these things, and supply chain, procurement process, everything we did gap analysis and trying to plug the loopholes and plug the gaps quite early on. What about next slide, please? Now, battle lines. We have a saying that Yuddhagala Adisthanathil Nammal Neru. So this is battle lines. Now, when we face a disease like COVID, ordinary measures are not enough. We really have to pull out all the stops and go in for a real hard battle. It's just like drawing battle lines. It's like a war breaking out in some place. And when there's a war, all of us depend on our defense forces, the Air Force, the Army, and the Navy. These are the people whom we look to as saviors, and there's a real war which is going on. And they save our country. So there's a lot of respect and saluting those people. I'm using the same words here: Air Force, Army, and Navy. So our battle lines in the health department, we immediately set up something called a multi-divisional or multi-component control room. So up to 18 different aspects were dealt with by this control room, central control room, set up in Trivandrum in the headquarters, the Directorate of Health Service, where we had good teams of young, aggressively working doctors and other helpers to look after various aspects, like, say, just like I mentioned, supply chain, medicines, oxygen, ambulance transport, ward services, training, so social media, then the helplines, everything, every aspect was covered by the control room teams. Then another good thing which we were able to do, or something that contributed to success in the future, in later times, was the lines of command. So we immediately drew up what we call undisputable lines of commands, that every order has to come from such and such place. So the Principal Secretary of Health will pass an order or make an order based on discussions. It will come down to the Directors of Health Service, the Director of Medical Education, Director of Insurance Medical Services, and then that will go down to the it will come through the Mission Director of National Health Mission. Then they will go down to the districts where the DMOs and district program managers are there, and from there it will go to the doctors and the medical institutions. So this line up and line down, and the line up of from bottom, all the events that happened at the microscopic level, ground level, those will be passed up in the same line. So these people are comparable to the generals and the commanders and the admirals and of the just like the generals in the army and the Air Force commanders and the admirals in the Navy. These directors and the principal secretaries, the mission director, and on top there was the biggest mission director, the director of the whole show. It was our health minister, who was there not like a sort of big authority sitting elsewhere, but just like so down to earth. She used to come and sit with us in our ordinary rooms and around the table all the time. It was a virtually almost 24/7 kind of presence. Along with every one of us, she was also there, and that was a very strong morale boosting presence. And she was really live, spot on the issues, and all the decisions. Because of that, we could take the decisions without any delay. Now, ordinary course of events, now you say make a decision, send it up to the ministry or somewhere for ratification, wait for the comments to come back. But here the government is sitting inside the control, so then there is no delay. So that's sort of line of command. Then the troops, this deserves a lot of mention. Frontline and backup troops. I will go to a description of whom the troops are. The troops are the entire group of staff who were dealing with this thing at first-hand level. I will come to that later. And then another big component of our war and our victory so far, a good thing so far, is the public also has been functioning like an army to a reasonably great extent. I wouldn't say 100%. I wouldn't say exemplary, but to a good extent, our literate public, they have cooperated with a lot of things. Some things are not followed into the true spirit and letter, but a lot of things they have complied with and cooperated with the department and our guidance and all that. So they also contributed to winning the battle and maintaining successes one after the other. Next slide. So ground zero is where the action happens. The hottest place, the most dangerous place is ground zero. And there, the field staff. Now, these field staff is a name that a lot of people don't know, because when you say hospital, the image that comes to people's mind is doctors and nurses in white coats and doing miraculous operations and saving people and putting people into ICU and saving them and all that. But Kerala, we always say there's a Kerala model of health and all these things. We are on a par with the developed world. And that victory is due to our field staff, who are the unsung heroes of the whole show. Unsung heroes, why? Because a lot of people don't even know of them. They are the health inspectors, the junior health inspectors, the lady health inspectors, the public health, junior public health nurses, the public health nurses, then ASHA workers. These are the people who go to the field. They go out to the primary health centers, which are basically preventive units, and go to the field, talk to people, they put their finger on the pulse of the people and know what is happening. So these are the people who really made a lot of things into it. Real what you call positive impact they created because of their actions. One group of field staff. Another group of people who put in a lot of commendable service at the ground zero, or were the ambulance and vehicle teams. Because ambulances, we had our own ambulances with commandeered vehicles, and so they had drivers and emergency medical technicians and all these people. So they were actually dealing with a very dangerous situation at close level. And they knew that the consequences could be very bad, but in spite of that, they were dealing with everything at a very close first-hand level, so close to death and danger, but without any fear. They were doing that. Commendable. Hospital staff, naturally, doctors, nurses, nursing assistants, lab technicians, the ECG people, the X-ray people. That is, of course, any medical issue, hospital staff are there. But again, I would like to comment that we should realize that these people are facing death at any time. They're just like soldiers on the war front, at the front line, facing bullets, because there are these viruses flying around. No virus has any sympathy, no virus has any human considerations, and facing the viruses at that level, it requires so much of courage, dedication, and the mentality of sacrifice. So that is what they were doing right there. So the hospital staff. Then lab teams, laboratory teams fall into hospital, but again, handling dangerous samples is something very difficult to do. So that was again another difficult thing and very courageous action by those people. Then other departments like police and the revenue department people, who again were part of our the fight. So they also developed. Can you hear me? Yeah. Am I clear? Am I audible? Police and other teams were also there at the ground zero. So these people really deserve a lot of kudos and
comments. Clear.
Okay. Next slide, please. Yeah, this was another component of our component which contributed to our winning battles. Guidance. So we were able, because this is a new disease. You will remember or know that COVID was named novel coronavirus. Novel is that it's a totally new virus. It was not there in the past. We were facing it for the very first time. We were facing the disease, its consequences, its effects. Everything was being faced by the entire world for the very first time in history. So Can you make the slide a bit bigger? I can't read the slide on the screen. So we were facing a lot of, yeah, thank you. We were facing a lot of uncertainties there. And at that time, when there's so much confusion there, the presence of proper, can you excuse me 1 second, please? Sorry for that. Yeah. So, yeah, guidance. So these, when there's uncertainty, people need to avoid confusion because wrong actions can waste time and have bad consequences. So we started putting out a flood of advisories, orders, protocols, standard operating procedure, protocols, and authenticate, and they were all authenticated in the proper manner so that nobody would have any doubt of where they originated. We also what we call and made efforts and arrangements for immediate dissemination of all these things to right down to every person. And everything was put on the net. People were looking at the net 24/7. And these guidance components were all originating from a policy think tanks. There were separate and different policy think tanks where there were experts with a large period of experience. So many people, each person with so many years of experience. So the total amount of brain hours of this think tank was an astounding amount of experience and knowledge and information going into the guiding of all these think tanks. So next slide, please. Then another thing which contributed to success was the information education and communication component and general communications. So general communications, information education and communication, one thing was we put out a lot of modules and training material. And these training materials were not the traditional ones that you put out in books, but we had things on video, we had things on the net, we had interactive type of things, self-learning modules, all these things we had made. And this was all posted on the net in the web and other places. And for general communication, we also made extensive use of the new technologies that people were used to. At one time, it was all books and all, but now people are used to smartphones and technology and other software. So we made use of the electronic, what we call the new era electronic age of communication methods to get things across. And also we had put about good communications on about dealing with people, about the what we call dealing with issues and personal issues and counseling and supporting and helping and all those things. So everything was there. So face-to-face communication, information communication, and also electronic communication about the contents and training modules and all that. So a lot of communication was done that way. Next. Data correction. This is a very important component. So right from January itself, we had made extensive components. The slide is illustrative. Those things, what you see there are illustrative, that we were looking at the data in different modes. So all the figures we collected, we had, right from the beginning, we had made arrangements to correct various aspects of this, not just numbers and simple things, but we in fact looked at such a varied kaleidoscope of data inputs. And many of them contributed to further good decisions. And these were analyzed in different methods. We converted them into graphs and tables and whatnot, so that we could get some inference out of those data. Data collection without analyzing and thinking on that analysis is of no use. So we had people and teams who were trained to sift out information and get behind the scene information and meaning from these data and graphs and tables. And we also have our live dashboard now, just like any other state and country. We have a dashboard which is GOK dashboard, where all the things which are happening right now, we post them as up to date as possible. So this was part of the effort which was guiding our future actions. Next. Media handling is something very, very sensitive and important during a mass pandemic of this scale, because we know that media can be a very constructive approach, but media if not guided and supported and educated properly, it can contribute to panic also. So this is something that we learned from long back. I remember from 2009 time, up to that time, the general trend was that the health department was very secretive. That is what we always heard, that whatever was happening, it was kept under wraps generally, and it was hard to get information out. So what the media would do is they would have investigative journalists going and digging up facts, and then countering the department with those facts and challenging the department all the time. So it was that sort of thing, and anything that they found out that we had hidden would come out in black and red headlines and all that. But from this time, I'm proud to say, I'm happy to say that the media of Kerala suddenly matured. Right from 2009, we devised a policy of transparency. And I remember that at that time, we got the then minister's permission to go public with all sorts of unsavory facts. So even if you had 14 deaths in one day, which was unthinkable at that time, we went public with that. And evening 5 o'clock, I remember we would send a bulletin and an email to every single media house and media address. So that finally what happened was the media lost the need to keep digging for facts, because all the facts were put on a plate, garnished and given to them. So that way the media started responding very favorably. And we discussed things with them. We told them what kind of things are useful for the public. And they rose to the occasion so brilliantly, and they became a very constructive part of Kerala's public health team. I'm proud to say that. And we have such good relations with so many media teams and media houses and media channels and papers and other methods, radio stations and all that. Now everyone works towards common good. So that is something which we can say with pride about the Kerala media with regard to health issues. Then inside the media itself, this TV was there, because going live is something very delicate. It's just like a cricket player, a batsman standing in the crease and not knowing what kind of ball he is going to receive from the bowler. So this is the challenge of going live on public media, especially on TV, where people can even see your face. On radio, it's okay, they can only hear your voice, but on TV, people see your face also. So it was a challenge, but it's a challenge which I enjoyed. And I was made the single state spokesman or single spokesman for the state right from that time. And I'm proud to say I've been doing that with a lot of happiness and facing challenges with a lot of confidence. So with support from all our team members and the directors and other people. Then we also found that sensationalism slowly disappeared, and it was all coming to a good steady feed of good information. And I'm sure that you have noticed for Corona, not much of sensationalism happened in the state of Kerala, but good information was there in large doses. Then access to the media also was important, because at that time, I remember from that time onwards, my number was always busy, because I used to respond to little calls from everyone, whoever it is, whatever time, and that really helped to build up the trust and rapport between us, so that we could deal with, do things together, the media and the department. Social media is something new, where it's run by the public themselves. So there, the challenge is people can put up rumors. I'm sure that you've seen such a lot of rumors, especially during the time of Nipah. There were so many rumors that you saw. And there were exotic rumors coming up. And even during COVID initial period, we had these exotic rumors. So we decided to become tough. And we reported all these things to the cybercrime units and other places. So finally, we had policemen and police teams going and hunting out these people who sent false things. And we had charged cases on them. And finally, that trend of putting up rumors quietened down to a significant extent. Now we get very few rumors, but still rumors are there. I will just say what to do when we see a rumor or potentially inaccurate report on the social media. Next slide. Yeah. So coming nearing the end of this presentation, this is something very, very important, extremely important, I would say. It's the state health department run helpline. We run a helpline, the Department of Health Services and National Health Mission Kerala. We run a helpline called DISHA. And the number is two numbers. One is 1056. Second number is 0471 255 2056. It's a wonderful thing. So many volunteers are there, and volunteers and the staffers 40 to 70 people there sitting 24/7. This is still there in existence for the last several years, but from the time of Nipah onwards, this went into real war mode. And for COVID, just wartime all the day, every day, 24 hours into wartime in the Disha control room. And whatever call comes in from the public to these numbers, they answer the phone, talk to them, decide it is Swagatham, and then according to what kind of call they get, they switch to the appropriate officer. If it's an emergency medical call about an ENT problem, it will go to an ENT doctor. Another person calling to know how do I come in from, when I am traveling from Andhra through Tamil Nadu and coming into Kerala, how do I come? What are the rules? Then it will be given to a surveillance officer. And other person says, I have a chest pain, is it gas trouble or a heart attack? It will go to a physician. Another caller says, my child is crying non-stop, baby is 2 months old, non-stop crying. The call will be switched to a pediatrician. So that means there are so many doctors and specialists behind the scenes volunteering their services 24/7. They are not bothered about their sleep being disturbed, but they'll answer your phone call. So that's the wonder of Disha. So this means for any emergency in your house, major or minor, you can call Disha with confidence. Your call will be answered, and you will be able to talk to a very friendly doctor who will give you advice. Likewise, doubts about medicines, prescriptions, tests, brand names, medicine names, and also clarifications about rumors. If you call Disha, you will be switched to somebody, some doctor who is off duty. So they are more, we doctors are generally more friendly when we are off duty. Inside hospital, we are also stressed out, and we are so short of time that we might appear very, very, short-tempered. But outside hospital, I think we could appear more friendly and we are more relaxed. So we will answer your calls through Disha. So this is one of the most useful things for Kerala public. I would request each one of the audience here to save these numbers, the Disha toll-free number and Disha landline. Save them to your mobile phone and share them widely to all your friends, family, WhatsApp group, everywhere, so that all your contacts know that there is this number whom you can depend on at any time. And one simple request is, funny thing that please don't call for simple things or doubts during the night time at odd hours. Say, cause of common cold, what are the kinds of viruses yet to come? Don't ask. I would request people not to ask just information type things at night. But emergencies anytime. But other things you could mainly preferably put during the daytime. So next slide. Next slide. Yeah. This is another thing which we do. We have our own radio studio. Health service department, we have our own radio studio right inside our office. So we produce so many radio programs on topical health issues, just 15 minutes a day. Very simple, very good speakers, and very, very topical issues. It is there every day, just 15 minutes on all the 9 FM stations in Kerala and all the AM radio stations in Kerala. So that means that anybody with a radio can listen to these on the car radio, phone radio, whatever radio. You just need to find out which is the nearest FM station that you hear clearly. Look at the newspaper, find the time of Arogya Kerala Radio Health Paribadi, and tune in at that time. You will get addicted to this because it gives the simplest of information to all people at all times. And these are all topical things, very common things, and such a wide variety. Next slide. Convergence and multidimensional care. Care is something we're proud about, because care is what we doctors and nurses, we are supposed to give care. That is what we are doing. But for COVID, that care crossed all boundaries, and usually it's inside the medical department. But here, the care aspect went right out of the medical department also, and so many other people contributed and collaborated. We had devised special policies for elderly care, baby care, children's pediatric services, psychosocial support, something very important, because COVID is a distressing thing. People on quarantine, people on isolation, they can feel, because there are so many suicides, so many people attempted suicide, and this psychosocial support team comprising of 1,200 specialists inside our team, they were there 24 hours. They are still there. So if you give a call to Disha and ask for a psychosocial support team, the person will be connected to one of these members, and they will then guide you out of any issue, out of any mess, out of any depression, out of any sadness. So that is some wonderful team there. And livelihood care, part of the government service, general government services. You see, food and groceries are supplied to people. Students, online learning, the entire set of student business now that's been handled beautifully by to the best of their ability by the education department. Adolescent care, because teenagers are one group of people who are affected, but they don't show it. or they show it by they pretend otherwise. So teenagers are very delicate, sensitive group. So we have a totally special department for teenage care and adolescent care. That is also accessible through the Disha services, Disha number. And then the COVID warriors, I mean, so many doctors and nurses landed in health issues. In fact, we have had deaths and all that. So many, some health workers, 5 people now, by this time lost their lives due to COVID and due to the battle that they are fighting for the common man. So we were able to harness the PMGKP insurance, Pradhan Mantri Garib Kalyan package insurance of 50 lakh rupees for a COVID warrior, any person on government COVID public care. We say government because that is for public care, and who was engaged by the government for COVID support services or COVID services, and who died. So there were two nurses, 2 attenders, and other people. And recently, one doctor lost his life in Ernakulam. So this is package, and already 4-5 of them have been given that PMGKP insurance package of 50 lakh rupees. Next. Yeah, hospital services right now, because non-COVID, because everything is not COVID. We have to remember that other illnesses are there, heart attacks are there, chest infections are there, a lot of things are there. And COVID really swallowed everything for a long time. And other services came to a virtual standstill. Many hospitals were shut down and diverted entire effort to COVID. So people were initially left at a loss what to do, but now we have started restarting those non-COVID services at the hospital level, primary health center level, in the field, and also for people who are afraid to come to hospital for minor things, but they need medical care. There is something called e-Sanjeevani OPD.in and /Kerala if you want it in Malayalam, otherwise it's in English. So this is a sort of virtual OP where you can choose a department, choose a specialist, and finally you can talk to the doctor live, face to face. The doctor can see you and you can see the doctor. And you can avoid a lot of hospital visits for minor issues through the e-Sanjeevani OPD. Just typing in this address on the web browser, and you will opens up a page with instructions which are easily followable, so that people can finally navigate the whole thing and get to a doctor who will answer the queries. Also, counseling services are there on e-Sanjeevani OPD for teenagers or their parents. Anybody can talk to a counselor for any amount of time on e-Sanjeevani OPD. Next. So finally, it was challenges all the way. And generally, we say that some you and battles, when we talk of battles, we say some you lose, some you win. That is the general trend about battles, the general proverb about battles. But here in Kerala, we were able to convert that phrase from some you lose and some you win to a few you lose, but mostly you win. So mostly we won so far. Fingers crossed. So we need to wait and see what happens next, because COVID is something so unpredictable, and public behavior also is unpredictable. Public disobedience is unpredictable. Public non-cooperation and public nonchalance is unpredictable. So we need to see how we'll go. But hopefully our literate public will keep their senses intact and help the department to fight the battle properly. Next. So with that, I'm coming to the end of my presentation. Thank you very much for your very attentive listening. I hope I was clear, but I'm sure that there was a chat box and other things where we can discuss some of the issues that are remaining to be seen. So on that picture, I would request you to look at that picture more closely, the picture with the thank you. So it is hard work. So I would put on record our appreciation to so many doctors, nurses, and other staff, and even policemen and other department people who have been away from their family, from their wives, from their husbands, from their children for so long periods in the service of the general public and the common man. They have foregone all their comforts, their money, their conveniences, their family, their relationships, everything they have foregone during the entire 10 months or 11 months now, just to care for all of us. So that is something, the hard work, there's nothing to beat that hard work. And that is what makes the difference. So I am sure that we'll all work very hard to continue to work very hard so that we'll keep winning and not losing. Thank you so much.
Thank you, sir. Thank you so much for that very informative session, sir. We shall begin the interactive session shortly. We have some questions from our viewers. May I invite Dr. Amar.S.Fettle, back to the dais. I request Shri C.K. Suresh, Director, Atma Foundation, to facilitate the question answer session.
Good evening, sir. First of all, let me on behalf
Good evening,
of
sir.
all people in Kerala, thank you and your team for the wonderful support, services, help that you are giving to the community. Our heartfelt thanks. And the first question is what prompts the medical service professionals to serve people like this?
That's a very, what do you call, a sort of question which leads me to dream, because for a lot of doctors who are in service, this desire to serve must have been fired by a dream somewhere, sometime. For me, I don't know when it came in during my pre-degree, or what we call now +2, that we call that pre-degree at that time. I was a bookworm and I used to go through the entire shelves of books in our DrAmarS public library. And there was this shelf of books called History of Medicine, one entire huge shelf with so many books, several score books called about History of Medicine. And going through those, I was able to read about how we progressed from Stone Age medicine and came to a lot of things, dramatic things like the introduction of anesthesia. Anesthesia is something people don't even see anesthesiologists, but just imagine if an operation is done without anesthesia, even a pinprick is painful. Can you imagine somebody cutting open one's body without anesthesia? But this was the way it was. And the discovery of anesthesia then brings into perspective how dramatic that was and how the abolition of pain and so many new things have come in. So that set me thinking and caused me to go into medicine. That's for myself. But then we doctors, though now in Kerala and India, we face a lot of challenges, accusations, and all these things. A lot of lack of understanding, but still there's a lot of joy when you see a patient smile. And as a pediatrician, I know my patients are children, and they can't even hide their emotions. Adults, maybe they feel happy, but they will hide their emotions. And there are a lot of adult patients who, when they recover, they have a very grumpy face, as if this recovery was their right and the doctor had nothing to do with it. But these children, they immediately start jumping and playing with you in the ward. Even inpatients in the ward, when we go for rounds, they start playing with you. And there's no happiness to beat that kind of happiness. So that's maybe what fires this sort of similar things must be firing the desire to serve in most doctors and nurses.
Has really the suffering from COVID has come down after all these months?
Could you repeat that, sir, please? The suffering?
I think the individuals having COVID had been so scared, or they were suffering more earlier, and now it has come down.
Suffering. It has come down, I will say, in one way, because in the initial period, there was so much of fright that if you get it, you are done with. You're done for, not done with, done for. And you can die at any time. And that was the amount of stress that the initial 3 medical students, Thrissur, Kasaragod, and Alappuzha faced. And the kind of stigma which the neighbors associated with those people was astounding. And their courage also to remain 28 days quarantine. Now, even 14 days is difficult. Even if you find 7 days difficult. But at that time, those people, they experienced a 28 days. Not only those people, all the people at that time, they all experienced 28-day quarantine periods. Can you imagine 28 days shut up inside a room? So that sort of distress was there at that time. But now courage has come in, support services have matured, and we know that there are a lot of help services. And the fright has come down because so many people to hold your hand. So I think that has come down, and the hospitals and all that are better geared to handle that thing. And so we have much more, much better level of courage and reduced suffering, I will say.
What is your opinion about one health policy in fighting diseases?
Could you make that a bit more clear? One health policy?
It should be single health policy, support. What is your opinion about one health policy in fighting diseases?
It's sort of convergence that we mean, but what is exactly meant by one health policy?
Maybe about different type of medicines, and today also being a medical.
Okay, yeah. Today is a very significant day because there was a huge protest on this day, by us doctors of modern medicine against the policy by certain decision makers of mixing everything together. But mixing things, it is just like making a curry. It can be very dangerous. You do it in the wrong way, it can be so disastrous that our unsuspecting public and other people who ought to deserve good care will land up in a lot of mess. So systems are good. All systems have their merits and demerits. And as people say, you cannot. We don't go with the belief that people always say modern medicine is so full of side effects and all that. But naturopathy is totally safe. Ayurveda is totally safe. Homeo is totally safe. No, no. Every system, even drinking plain water, is not very safe if you do it just uncontrolled. So how you do it is very important. So everything has its own risks, benefits, and dangers and advantages. So it has to be balanced properly. The users can have their choice of going for any one system or whatever, or have a group of mix of systems according to the need. But medically literate and medically aware, then they should be able to make proper choices also. And systems let them exist in peace. But fighting with each other is not a good idea. But here we are forced to do that because there is this unscientific mixing of streams and trying to produce half-baked doctors with no knowledge of any system.
Okay, sir. Gratitude from the heart of hearts, and all the best wishes for you and your team.
Thank you so much. And
Thank
again,
you very much, sir.
I would like to reiterate that it's not me alone;
I
it's a
request
big team.
Professor Dr. G. Veerakumaran, Professor and Head of the Department of Cooperative Management, KAU, to propose the vote of thanks.
Respected Chief Guest of the Day, Dr.Amar.S.Fettle, learned colleagues, invited guests, student friends, ladies and gentlemen, good evening to you all. Dr. Amar.S.Fettle, my brother and best friend, delivered the address fabulously. In his speech on Kerala model of public health, with special reference to Covid-19 pandemic, endorsed the successful management of COVID-19 to the entire team, namely field staff, ambulance staff, hospital staff including paramedical staff, lab teams, police people, revenue staff, and he has not taken the credit. That is his humility. My dear brother, the talk is really an eye opener and will be useful for all those who have listened to you. Sir, brother, on behalf of the Professional Trainers Club and on behalf of me as well, we extend our heartiest thanks to you. Thank you very much. Thank you. Next, let me congratulate and thank Ms. Parvati and her team of Atma Foundation for their wholehearted support as strategic partner from its inception. It's also my duty to express our sincere thanks to the Institution of Engineers Thrissur chapter for their support as knowledge partner. Last not the least, I thank all our participants and thank you one and all. Thank you. Thank you very much.
With this, we conclude the final session of the 5-day webinar series, Ubuntu. Thank you, viewers, for staying with us throughout these 5 fabulous days. Thank you once again. Good night.